Hi, Mama. Today, our guest speaker is Cammie. She's a registered midwife, and she's going to talk to us about C-sections. So, take it away, Cammie.
All right. Hi, everybody. So what is a C-section? First of all, a C-section is a surgical procedure where we deliver the baby abdominally when vaginal delivery is no longer possible or it's contraindicated. So cesarean delivery is a different way of delivering a baby through the abdomen rather than the vagina. It's performed by an obstetrician, so a specialist, a surgeon who is going to conduct that surgery, and an assistant. And the assistant can either be a midwife, a family doctor. Usually those are the people that help. There's going to be a lot of people present in the room that all have different roles and jobs. So you'll probably see, well, there'll be an anesthetist who's present, who's responsible for the anesthetic, which will either be, that depends. In very rare cases, a general anesthetic where you put to sleep, or it could be a spinal anesthetic where you're fully awake, but numb, completely numb from sort of the breast down, or an epidural if you already have an epidural. That can often be topped up so that there's no additional puncture. You're just getting an epidural and then the medication's topped up for the surgery. There's also a scrub nurse present. There will be a circulating nurse. There's a pediatrician who's present, often with a pediatric nurse or a learner. And then there's a nurse who's also present around where the pediatrician is. And in addition, there could be multiple other students and learners that are present. So there's a lot of people in the room.
I was just going to say that it sounds like there's a lot of people in the room. Is
Yeah.
that, do you find that moms can feel overwhelmed with all the people, or is it more like expect all those people, they're all there to help you?
I think a bit of both, but definitely being aware that everybody has a certain job. The rooms are very big. There's a lot of people in there. So everybody has a certain job to play in that procedure. And often once the baby's born, half those people are out of the room. So yeah, it can be overwhelming. So it's good to be aware of, that it can be a really busy room in there in the operating room. There's lots of different times when a C-section might be needed. So there's primary elective reasons, which means that you've selected to have a C-section. So in that case, like for instance, a breech delivery. So if you're breech, which only 3% of people will be breech at term. If there's like a placenta previa, if there's previous trauma or a previous shoulder dystocia where it's been a really difficult delivery, then the obstetrician may have offered a primary elective cesarean section. Sometimes if the baby is suspected to be really big, but that's a bit less common. So those are kind of like primary reasons why you might select a C-section. Then there's an elective repeat. So maybe you've had a C-section before, and those are like if you've had a previous C-section in the past and maybe you've chosen to not try for a trial of labor and going right to a C-section. That's sort of like the most common reason. And then there's emergency reasons. So we call it an emergency anytime it's not an elective C-section. So even if you're in labor and everything's okay and the C-section ends up happening, it's still considered emergency on paper. And that's just because it hasn't been booked previously. So these are, most common reasons would probably be abnormal fetal heart rate tracing. So if the baby's heart rate is not tolerating labor for whatever reason, if there's a labor arrest, so either in the first or second stage, so either in labor or when you're pushing, maybe the baby's not coming down, maybe the baby's just not descending as we would expect. If there's any abnormalities other times in the heart rate, so if the heart rate is high, could indicate infection. If there's a failed induction of labor, so we're trying to get you into labor and it's just not working. Those are sort of like most common reasons for emergency cesareans. And then of course there's, the emergency reasons that are not that common, like a cord prolapse or something like that.
Mhm.
Then there's maybe maternal concerns. Maybe there's a fever for mom in labor. Maybe mom's just exhausted and can't go on, and we've tried everything else. And then there's maybe a choice. So maybe the surgeon has talked to the patient about, doing a forceps or vacuum or going to a C-section. So it's always, and sometimes there's cases where there might be a maternal choice that the person leans towards a C-section instead.
Well, that's a nice thing to know that it's just like an unplanned C-section is emergency, because the word emergency can feel quite scary, you know?
Mhm.
So
And
it's,
on paper, it will always be an emergency C-section, even when in reality it's not. So
mhm.
yeah, that's important to understand,
So
definitely.
how many C-sections have you been at in your career as a midwife?
Um, that's hard to say. Now that I'm doing assisting, I've been to at least 40 or 50 in that role. And then previous
So
to that,
sorry, you'll hear my dog, but what does it mean when you have an assisting, when you assist at a
yeah, so there's some midwives that have done additional training where we can actually assist the obstetrician in the surgery. So instead of a family doctor or a resident or another obstetrician, it's a midwife who's assisting. So we're actually helping with the surgery, which is great if it's our client because we can see what's happening. We know if there's any complications in the operation. Um,
How
so
cool is that? You can work with your own patients and
Mhm.
assisting their C-section, because not I'm sure not every midwife client gets to have that
Yeah.
experience. So
Yeah.
when you assist, Cammie,
Mhm.
do you um like are you in full gown gear with like helping with the incision, or what is your role?
Yeah. So the role is really to help the surgeon. So yeah, we scrub in, we're gowned, we're covered. So our position is on the other side of the drape, whereas normally as a midwife, we would be with the client and the family kind of assisting them. So sometimes that still happens. There's another midwife who comes in to do that. But yeah, we're there to assist the surgeon. So we're helping to open the tissues and show exposure and help deliver the baby. The assistant actually brings the baby over to the pediatrician. So yeah, that's additional.
Can you walk us through like step by step? Like, so let's say emergency C-section or emergency unplanned. So let's say mom's not progressing, baby's not dropping. She said she doesn't want a vacuum or anything. So you say, okay, we're going to move to a C-section. So what would that look like? How would that like reel them in a different room? Like, what is she doing?
Yeah, so I mean, at our hospital, anything that's an emergency, so not a planned C-section, is done downstairs in the operating room. So there is an operating room on the labor and delivery unit that is for booked C-sections for the morning. So if that's kind of the plan and we're heading towards that, there's a bunch of questions that usually mom has to answer. There's a big questionnaire. We take out the jewelry. She's in a gown. And then once the decision's made and we get called down to go, the stretcher gets pushed, the bed gets pushed down to the operating room, which is through an elevator ride. So dad comes or partner comes as well. And then we kind of wheel into the operating room. There's a lot of people in there. The anesthetist sort of gets started with the patient. So they would do the anesthetic like we talked about, either a spinal or top up the epidural. It's very rarely a general anesthetic unless it's a real emergency. Usually our role as midwives, we're there with our clients to help them through that anesthetic part and make sure, because at this point, sorry, dad is not in the room or the support person's not in the room. So they get kind of sent to like a waiting room. So the person's all alone essentially without their support. So that's why it's important for us to be there with them. And once the anesthetic kind of gets in, then they're laid down quickly, and there's a big drape that goes up so that they can't see anything in front of them. and sort of all the prep happens. So there is a catheter that's put in by usually the obstetrician. There's not really any shaving that happens anymore that I've really seen in a while, unless it really needs to be done. The belly gets washed off with an anesthetic or antiseptic. And then sort of once all that's ready to go, things happen pretty quickly. So the patient's lying down, sort of with the arms out, and the anesthetist is there helping them with all of that when the drape is up. And then we kind of put like a sterile drape over the belly and just prep the skin. So we just check to see that they're frozen and that they're not feeling anything before anything goes further than that. Once that's done, then they call in the support person to come in and join. And yeah, so basically, I mean, quickly kind of the steps that happen are once everything is prepped and ready and the patient is frozen and in good shape there, then the incision is made. So it's a bikini line cut usually, unless it's like a very rare emergency. So a very small incision, probably about that big, under sort of a couple fingers above the pubic bone. So really quite low.
And horizontally, correct?
Yeah, so it's called a fan and steel incision. So it's quite small. So that goes through the skin. And then the subcutaneous tissue is next. So that's like the layer that has the fat. So that's sort of cut into as well. And then under that is the fascia. So that's a very strong kind of white connective tissue, very, very, very tough, that kind of holds everything together.
That would be very interesting for me to see, because in yoga trainings, we talk about fascial tissue, and that's what you stretch and how strong it is. So that's the one that's harder to get through, the fascia.
Yeah, it's absolutely really tight and like hard to get through. Yeah.
Okay, keep going. Sorry, I'm just
yeah.
very
So the
interested.
fascia is cut, and then underneath that would be the abdominal muscles. So those are not cut. So usually, like, the most common are the rectus abdominals that are sort of like this, put together with a layer of connective tissue in between. And those are not cut, they're just sort of opened.
Oh, that's cool.
So the rectus abdominal muscles are separated kind of that way laterally. And then underneath is the peritoneum, which is just like a thin membrane tissue that kind of holds the contents of the abdomen together. So that's entered and opened. And then there's sort of the bladder underneath, which some people will kind of hide. But then the uterus is under there. So that's the main thing. And then the uterus is opened very, very carefully, because the baby is inside the uterus. So very, very, very carefully. If it's a planned C-section, you'll probably have a big sac of fluid. So once the uterus is opened, there's a big bag of fluid that's cut, and the fluid gets suctioned, and then the baby comes. If it's somebody who's been laboring for a while, then you might not have, or been ruptured. If the membranes are ruptured, then that might not be there. So being very careful to go through that uterus really carefully and slowly. And then you can see the head, and the surgeon will put their hand in and flex the head to kind of deliver the baby through the incision that they've made. And sometimes they need to go wider, but you always want to be careful, because there's vessels that go down that you don't want to, you want to be careful with that. And then the assistant is pushing the baby on the tummy. So it's very normal at this time for moms. We always warn them that you'll feel like there's an elephant sitting on your chest. There's a lot of pressure. And so the epidural or the spinal will take care of pain, but it won't get rid of physical pressure that you're feeling. So when we're actually physically pushing the baby out, there can be a lot of pressure, like on the chest and the abdomen, and it's very short, but definitely that's something that can be expected. And then the baby's delivered, and we usually always wait for delayed cord clamping, so at least a minute, unless the baby's compromised and not doing well. And then the baby goes to the warmer, which is behind the patient with the pediatrician, and they kind of look them over. If everything's good, baby comes back to mom pretty quick, and we try and get them latched on and nursing pretty quickly in the operating room.
Wow. So then, and then do you start to sew up? So how do you start? What do you have to do anything with the uterus? Do you have to sew the uterus up, or what
Yeah, so
happens there?
the uterus is the most important piece because that's where bleeding can come from. All the blood flow in this giant organ. You have to be really quick with that. So the
And do
uterus
you
is the
reach
first
in
thing.
and get the placenta? Like, how do you do the
The
placenta?
obstetrician does. They kind of just pull it out by the cord, like kind of like a normal vaginal birth,
Birth.
essentially.
You
Yeah.
don't need the oxytocin or anything to release, or do they still do that
They
often?
give yeah, good question. They give carbetocin now, which is um another medication that causes contractions, which is actually way better for bleeding, especially in C-section. So the blood loss is a lot less. So that goes in immediately once baby's out. And so the obstetrician usually just kind of helps the placenta out, sometimes manually, but usually they just sort of pull it out, just like a normal vaginal delivery. And then right away, the uterus is closed really quickly. So that's sort of the part that is the most attentive and time sensitive because there can be
And
a lot.
is it like stitches that dissolve on the inside? Those
Mhm.
ones?
Yeah, so
Oh, very
everything dissolves on the inside. So the uterus is closed sometimes in one layer, sometimes in two layers. It just depends. Um, and then, everything's inspected. They make sure the tubes are normal, the ovarian tubes, and the ovaries are normal. So they have a look around. We make sure there's no clots or blood, and then we kind of go in reverse and repair everything else. Um, yeah. So
Isn't
the
that
abdominal muscles
amazing?
aren't. Yeah,
That's
it's
incredible.
yeah. So the abdominal muscles aren't repaired. They're just brought back together. Like
Together.
they sit back together, which is why there can be a lot of like core instability, with any delivery, no doubt. But yeah, and then like the fascia is repaired.
Is that also another layer of stitching then, fascia?
Yeah, yeah. So every layer that's kind of cut is repaired, except for usually the abdominal muscles. Unless they need to be just by one suture. So the uterus is very carefully repaired, often in two layers. The fascia is repaired in one layer. The subcutaneous fat is brought together to make it strong. The skin is brought together. And of course, in all of that, looking to make sure there's no like bladder injury, no bowel injury. The skin can be repaired either with sutures or with staples.
Mm-hmm.
It's totally surgeon dependent. There's been absolutely no difference in outcome and healing by research.
Mm-hmm.
Most patients prefer sutures because they don't see staples, and the staples need to be removed usually day 4 or 5. But it just depends on the surgeon. I would say, like here in Kelowna, it's kind of half and half.
Half
We
and
do
half.
staples and
Um, so then when does the anesthetic like wear off and she starts to feel that it's painful and very tender there?
yeah, so I mean usually their C-sections are done by a spinal. So I would say a couple of hours is usually when it wears off, but there is like a long-lasting medication in there that will give relief for quite a while. They do give some suppository medication in the operating room.
Mm-hmm.
That's really good for about 12 hours. So the pain control nowadays with C-sections are really good.
Mm-hmm.
Um, and then, so after the C-section, we go to the recovery room where mom kind of recovers for usually around 2 hours or so until they start getting feeling in their legs and can move. And baby's with them the whole time. We try and get baby feeding right away. The hospital stays about 48 hours, I would say, to be safe. Some moms who've had babies before and are doing really well can go before then. If there's any issues with feeding or with healing, then you might stay longer than that. But usually about 48 hours is pretty common.
So what
Uh,
do you tell your clients then once they're sent home after the 48 hours? What should they do for like how long will it be till they can feel themselves?
yeah. Yeah, I mean, with any delivery, we say like give yourself a good 6 weeks, right?
Mm-hmm.
Internally to heal. Definitely with a C-section compared to a common vaginal delivery, you're going to be more laid up. So I always recommend people having someone there for the first week. Once you're home, you're not able to really lift anything heavier than your baby for a couple of weeks. We don't want you doing too much in terms of like stairs or housework. So it's really good to have really good support lined up. I always say with the C-section, the first week is often pretty hard. And you're dealing also with a baby who's feeding all night long and sleep deprivation. Maybe it was a really long labor and you haven't caught up on sleep. All of those things. So the first week is really hard. And then often by the end of the second week, I find most people are feeling a lot better. So, a good 2 weeks of support, I would really recommend. And then, sort of by that time, you can start kind of going for a small walk and doing a little bit of light housework, kind of getting out of the house. But typically you shouldn't drive yourself for a few weeks. You're not picking up anything heavy. The more you recover and take the time to recover, the better that recovery is going to be. Whereas if you push yourself and go backwards, that's always hard to catch up. So,
Yeah. Thanks so much. I think that for most moms, they don't know. Like we were reading the current facts, our statistics is going into the hospital or having birth, you have a 33% chance of a C-section. And just knowing what the steps are, I think would help moms just relax and be at ease. Like I've had people take my course and tell me that they liked my breathing techniques because it helped them visualize or focus on a positive affirmation like I am calm, all is well. Especially when you said you're alone for a bit, like everyone is busy, it's probably very bright lights everyone can see, and you might be feeling those intense, fight or fright. So to keep yourself calm, like staying in a positive affirmation and focusing on softening with each exhale, I'm sure is helpful. And you've probably seen moms that have been stressed and then women that are relaxed, right?
Yeah.
So
And even if you've just the research kind of shows that if you are just well prepared and well supported, even if your birth plan doesn't go according to how you wanted, the outcome is like the satisfaction is better. So I think just being prepared, knowing what the process looks like, knowing that sometimes babies need to be born this way, and just having good support and having yourself set up once you're home, you'll do a lot better with that.
yeah, and it's like you said, like we were talking about support today in class, just feeling that you're loved and supported in your room the whole time, right? That you're surrounded in love, no matter what turn your birth takes, and being prepared. The mantra, I've been prepared to, what was it? I'm prepared for birth on whatever turn my birth takes or whatever way my birth goes, to be just, I'm prepared for whatever turn this takes. And sometimes it's hard to, when you had your heart set on that, right? And then this is happening. So just remembering to, that you are loved, your baby is loved, and breathing in those affirmations. I'm supported, I'm in a safe space. Is there any last tips you would give for someone who is in or have like in a C-section scenario or postpartum or anything like that, who's watching this, who thinks, okay, in the back of my head, C-section is the scariest outcome or something like that? What would you tell her?
I think, just like trusting that sometimes babies need to be born this way and they're in good hands. And, I'm so confident in our surgeons and our staff, and just taking the time to recover properly, emotionally and physically, and to know that, it's a really hard thing when your birth doesn't go as expected for whatever reason or whatever course it takes, and to know that there's time to really work on that. I think both physically and emotionally is really important. So, knowing that there are times when you can talk about your birth and really share your story, and it's okay to kind of, mourn whatever birth you had in mind. But I think just being like really emotionally prepared for having your baby is really important.
Hmm. Yeah, the emotional level, like that, it's just incredible what healthcare providers do now. It's like this emotional support that
Mhm.
really you guys don't have time for. You have so many other things you're doing with the vitals and with everything that baby is. So it actually is the the caregivers and everything to make sure that mother has the support because it's so intense those first few weeks, and I can imagine about the healing process of not doing anything, lifting anything heavier than your baby for 2 weeks. How hard that must be, but it's so important to rest.
Yeah,
And
especially when you have another toddler at home or another child, right? That needs,
yes,
yeah.
that
So
needs you. Well, thank you so much for the information. This was really eye-opening, and I'm the birthing women in your life are lucky to have experts like you. So thanks again,
thanks,
Cammie.
Anna.